This video is an interview with Dorte Nielsen, who is a specialist physiotherapist from Copenhagen in Denmark. She is the owner of ProAlign Sports Physical Therapy, which is a progressive practice located within one of Copenhagen's largest fitness centers and with state-of-the-art equipment. ProAlign prides itself in rehabilitating injuries quickly and efficiently, and accepts referrals from sportsmen and women right up to Olympic level. I was made aware of Dorte during my interviews with Dr. Lars Blund when we were discussing the procedure of arthroscopic trochleoplasty for patients who have had recurrent patella dislocation, consequent on the developmental abnormality of trochlear dysplasia, where the combination of an abnormally shallow groove for the kneecap and a bony lump in the wrong place on the femur bone combine to allow ready dislocation of the kneecap. Dr. Blund dissects and lifts up the joint cartilage in the affected area, reshapes the groove, pares down the bony lump, and secures the joint cartilage back into place using bioabsorbable tapes. Dr. Blund's arthroscopic trochleoplasty patients are usually discharged the same day and are given a routine to follow at home until they come into Dorte's clinic after 2 or 3 days.
And they do range of motion exercises with a strap at home and some VMO exercises and then ice and compression, and that's it.
Mm-hmm. I asked Dorte how the rehab of arthroscopic trochleoplasty differs from patients with other patella surgery. And she explained that the main issue after the surgery was the marked swelling or edema from the trochleoplasty, as well as pain if the MPFL ligament had also been reconstructed. This MPFL ligament is a stabilizer that is often torn in patients who have suffered patella dislocations. She explained that rehabilitation in these arthroscopic trochleoplasty patients is not all that different from most knee patients, focusing initially on regaining full knee extension.
For me, it's I look at the signs for when I can proceed and not, and there I go by like a normal rehab program, and which is, I start slowly with increasing and getting the full knee extension, and when they have gained the full knee extension, then we slowly increase to the knee flexion. But for me, it's very, very important that they regain the full extension within the first month. And if they haven't, then we will have extreme problems with them gaining their normal gait back.
Regaining extension can be problematic in situations where the knee has not been through its full range of movement for some time, and where it has been maintained slightly bent because of pain or edema. Failure to walk normally allows the knee capsule at the back of the knee to tighten up, and also the tendons or the hamstrings muscles at the back of the knee become tight. At their clinic, they have a gravity-altering treadmill where patients can exercise within a special pocket of air that can reduce weight bearing in increments down to as low as 20% of the normal body weight. Dorte explained.
And we have the Ultra G anti-gravity, which is very, very helpful in this process because it activates the hamstrings in the walking process. So in that way, it's easier to get the capsule, the posterior capsule, to relax and the hamstring to contract normally and not be so tight. And then we can get the full extension easier.
She also talked about weakness of the quadriceps muscle, particularly the part of it called the VMO, or vastus medialis obliquus, and how they use electrical stimulation to get the VMO activated and firing normally again, as well as the use of compression leg wear to keep the swelling down.
And then we also use the electrical stimulation. And actually, I just had an interesting case where I was on vacation, so the patient was started later than what I would normally do. And she's a little behind in the normal rehab process, and we started it this last week, and now we are finally seeing the improvements. And it's been very interesting because she couldn't do like a straight leg raise, which I normally would have the patient be able to do it in 2 weeks. And she couldn't, and she's in the 3rd week right now, and now she's starting to be able to do it after we have activated the VMO and getting rid of some of the edema. We've had a lot of communications about the compression, because I think it's very important that they have the compression on at all times after surgery. And that means also a compression sock, and then they have the compression bandage around too, and they have it on at all times except from when they're doing the exercises, because it has a tendency to swell a lot. So the swelling will limit the range of motion. And it would also increase the pain on the pressure on the nerve endings. So thereby there will be more limping, and they will lose their crutches longer. And if we get the swelling out of the joint easier with the compression, then we will get the range of motion faster too. And we will increase the circulation by having them on a stationary bike, where we just slowly sit them and do like oscillations on the bike. So they're not pedaling around. They can't do that yet, but with a high seat, and then just sitting there and moving the pedals a little bit back and forth. And then on the anti-gravity machine also, to get them in the decreased weight bearing, so we can normalize their gait easier and they feel safe.
Dorte explained how closely they keep in contact with the patient's surgeon.
I would think that we have about 50% our knee problems, our lower extremity problems. But primarily, I work closely with Lars Blund, and there are other knee surgeons that also refer patients to us. But primarily, we have all of his trochleoplasty patients here, and have a very close correspondence with him every day. When the patient has been here, we correspond with him about the procedures and when to increase, decrease, and if there are any problems. Also, when things are going really well, we kind of videotape it and mail it to him so he knows what's going on with his patients. And so we have a very close correspondence with the surgeons here. Also,
that seems to be absolutely key to a good outcome, is because in the UK we have in many of the practices such a separation of the surgeon from his physiotherapist that of course the patient is the one who picks up the result at the end of the day, and that's really sad. So I really think that this kind of close relationship between patient, surgeon, and therapist is very important in any kind of surgery, but critically important in knee surgery, where the rehab situation can change quite rapidly. I'd like to thank Dorte Nielsen for her time with me today. Her contact details can be found on the Knee Guru website, including the clinic address and her LinkedIn profile.
Don't forget to like this video and subscribe to our channel. Learn more about your knees at kneeguru.co.uk.